I want to thank, as always, our hosts, IBIA. I want to thank NABIS, and just let you know that the big conference is coming up in New York City. We can actually have a casual conversations in person. Maybe I'll go out for drinks in a real place in New York. So that's going to be in mid-September, when COVID will be completely gone then. So you definitely want to save time for that. So I'm incredibly excited to have two Canadian friends. And I have to say, I was looking through pictures, and I have been to probably Toronto more places in the last, in that 10 years, and really made some amazing connections, starting with the Stringers. So I'd like to welcome the two top experts in Canada to share their stories with us today. So welcome, Charles, and welcome, Carmela.
Well, thank you very much for inviting me.
Yeah. Yes, thanks.
So we'll start with Charles. We'll put him on a time limit because we want to make sure we have time for both of you. But tell us a little bit about, I do know that you were born in the hospital in which you work.
Exactly. In Canada, I'm known as a local yokel because I never go anywhere. And I've enjoyed living in Toronto. And my wife, who's from Detroit, said that if I leave Toronto, I leave alone, because she loves Toronto. So I'm stuck here, but I've had a good time training at the University of Toronto and working in the hospital in which I was born. That's really a privilege. And I got interested in brain injury very early on in my career, because the hospital in which I was working at that time decided to start a trauma unit. And so, believe it or not, I went up in the helicopter from time to time to retrieve a trauma victim. And because I'm a neurosurgeon, it was obviously a brain injury that I was involved in, or a spinal cord injury. So I've had trauma in my system for a long time. And I guess the reason I was attracted to it is because there are so many unknowns and such a need for further knowledge, and for people who really focus on trauma. Patients really do better when they consult someone who's working in that field. And it's often not one of the most popular fields in neurosurgery, for example. But yet the mysteries of it are what really attracted me to it, because I felt I had something to offer in trying to solve some of those mysteries. So that's a long-winded explanation for why I like trauma.
Did you know as a little kid that you wanted to be a doctor? Was this the field that you always wanted to do?
You know, the women of my life have had a significant influence on me. My mother never wanted me to be a doctor. So that was one person who didn't like doctors, because doctors caused harm in her view. She had very definite views about a doctor having made some errors and resulting in the death of her favorite brother. And she never could get over that. And so when I decided to go into medicine, she was not happy. But
interesting.
Yet she loved me dearly, and there was no question of that. So she supported me in that decision. And my father didn't like the idea either. He wanted me to be a lawyer. So I was a bit of a renegade and didn't do what either of them wanted me to do, but that was the price, of doing what I wanted to do. So ultimately, it has really been a great career for me. I've enjoyed every minute of it. And in fact, I still like treating patients, and I still like trying to figure out the next step, like how can we do better? How can we do better in treatment? And certainly for concussion, it's been a hard nut to crack, if you'll excuse the pun. It's really been a slow process in making gains in the concussion field, but we have made significant gains. We can figure things out much better today than we could 10 years ago. And we have many treatments today that weren't available 10 years ago. So I can look back on it as being a period of growth in this field. And certainly with respect to prevention, which is another aspect of trauma in which I firmly believe, we've made gains. And we already talked earlier about the impact of the Stringer family, and as a result of their involvement, their more or less lived experience, as we talk of it nowadays, we now have a concussion law in Canada, which we didn't have before. And if it wasn't for that family, we wouldn't be as far along in prevention as we are. So that's a brief introduction of me.
Well, that's great. And I definitely want to come back to where we are with Rowan's Law. And now we'll switch. Where were you born and what was your pathway to the medical field?
Yeah, I guess I took the scenic route here. I went to film school and did communications before getting into medicine. And I was always interested in the brain, though. So even when I was in the arts, I had an interest in the mind and the whole mind-brain dualism. And so I got to the brain, I guess, from the back door. And from then, I've always been interested in what makes us who we are. And, my, I guess, non-romantic way, I think the brain makes us who we are, and anything that affects the brain basically changes us. So I'm a cognitive neurologist. I see people who have changes in their cognitive function, and I was coming back here to be a cognitive neurologist and seeing people with degenerative diseases like Alzheimer's and Parkinson's and frontotemporal dementia.
Wait, I got to stop you. Okay. You're in film school. You have film background, and then suddenly you're a neurologist. I need some more details there.
Not suddenly. No.
Yeah, like how did that?
Finished and worked, and then decided I wanted to go back to school and learn more about the brain. And because that actually was where the mind, like in my opinion, where the mind lived. So I actually went back to school. And
would you have had to go back to the absolute beginning? Because
pretty much, because your art degree doesn't really get you into medicine.
I looked into being an athlete. I was an advertising communication majors, and I thought, well, maybe I'll be an athletic trainer. And I talked to someone, they're like, oh, you are a freshman. Like, you don't even count. Nothing you ever did counted. So you started back at that first level.
Yeah. And I did. And I remember my first job, I was in photography, and I had done photography, and that's what I was working in. And so I had a friend of mine who worked at the M&I at McGill at the Montreal Neurological Institute, and was like, you would like MRIs, they're black and white, they're about the brain. Why don't you get into imaging? And I thought, yeah, that sounds really good. I'm used to looking at pictures. So I'm gonna get into imaging. And I did. And I thought, yeah, this is so fascinating. But
and do you think from that arts background and that there's an analytical side, there are things that you see because of that background when you're looking at a scan?
I think so. I mean, not just at a scan. I think my perspective is probably quite different, because education for people in the arts compared to science is very different. We grow up in the arts, not regurgitating things, not memorizing things. And when you are in science, at least in the early stages, a lot of it is, make sure you've got a good memory. And so you do have a different way of thinking about things and trying to look at the whole picture a lot more and looking for patterns. So, you know, there's a lot of overlap.
And was it more of a barrier being an, you know, a background of an art student, or being a woman and trying to switch the careers and, you know, move into what is mostly a male oriented space, which threw people more?
Yeah, I think it was both. You know, what was very striking to me is that in the arts, nobody really thinks you're very smart, I guess. I don't know. I never got that. I always did very well in school. I mean, my parents allowed me to go into the arts, but I had to succeed and do very well in, you know, math and, you know, when I was in high school. And then I got into science and medicine, and people thought I was smart. And I was
People want to know where you went to art school.
my first mentor said he was now recruiting out of film school for his future students. But yeah, it's very strange. People like to put us in boxes, and I guess as a woman, I don't really want to be put in any box. I think we should all be allowed to succeed, or, you know, do what we want to do in our own make our own journey. And it's, you know, it's not going to be the same. I mean, that's why I'm all about precision medicine. We're not all the same, and there's not going to be one treatment for everybody. Yeah.
And then when did you first come across Charles?
Yeah, so that's an interesting story. I was still doing my fellowship at UCSF, but I had taken the job here, and I was actually in Scottsdale, Arizona at some meeting, and I got a call from Charles asking if I'd be interested in looking at chronic traumatic encephalopathy, because I was a cognitive neurologist interested in tauopathy. So, you know, the changes in the brain that happen with some of these diseases. And one of the diseases I was interested had a lot of tau changes, and CTE has tau changes. And so I said, yeah, this sounds really fascinating. CTE could be an in vivo model for, you know, all kinds of tauopathies, which I still believe. And yeah.
So where were you living at? You were living in Canada?
I was living in San Francisco. No, this was before I actually got my job, like before I started, because I got hired. And so I think it was maybe April or May. I had just signed the contract, and I was coming here July 1, but I was at a meeting in Scottsdale, Arizona.
That's fascinating. So Charles, what caused you to reach out?
Well, this condition of brain degeneration after trauma really interested me, because during my growth and development, I actually was in neuropathology for 3 years of research. I was mainly looking at brain tumors at the time, but nevertheless, the field of brain degeneration and what happened to the brain with injury or with tumor was a major research activity of mine. In fact, that was what my PhD was in. And so when this problem arose with football players, especially developing cognitive damage and ending up with actual brain degeneration that we could put a name on, I was absolutely floored by this and said, wow, that's something we better take a look at, because I've seen a lot of athletes in my career, because originally I was involved in spinal cord injury in athletes. And so it was natural for me to move up. And one of the great neurosurgeons in the country who had an interest in concussion was Karen Johnson. I'm not sure if you've ever met Karen Johnson, but one of the first women who went into neurosurgery was a good friend of mine. She called me up one day and she said, Charles, it's time for you to go above the shoulders, meaning I should graduate from the spinal cord up to the brain. And she was right. It was time. And that happened about 25 years ago. And we've been friends ever since. And I haven't regretted taking on this interest. But Carmela, was golden for me because she had an interest in the cognitive aspects of brain degeneration, which was essentially what CTE was described as originally, and so many football players losing their ability over the years because the brain was degenerating. So that was something I really wanted to pursue, and fortunately Carmela was interested, and that's how the marriage occurred.
And at that time, when did the brain bank start? When was that research project?
Well, that started at about the same time. I would say 12 years ago now. It was one of the first brain banks to take an interest in CTE. And over the years, we've now collected 55 or 60 brains, not as many as has happened in some of the centers in the US, like the Mayo Clinic and Boston University have much bigger brain banks, but we've made a contribution to the field. And as you know, we've emphasized the fact that women should also consider donating their brains. And as I always say, I'm not interested in premature donations, but when the time comes and you don't have any use for it anymore, let us have it, and we'll see, what the source of your symptoms was and see if we can learn anything that will help somebody else. And I couldn't do that without Carmela. So that's really was an important aspect of our growth and development.
Yeah, and we recruit in Canada, and if you're interested in brain donation in your Canadian, or if you're American, or we have several other countries, if you go to the PINK Concussions website, it's Pink Brain Pledge, and there's questions that Q&A about brain banks, and then you fill out the pledge form and you pick which country, then you'll get information on the research study that we are discussing right now. Carmela, would you like to talk about the brain bank?
Yeah, so as Charles mentioned, it's really important for us to understand what is the cause of the changes that occur. The brain has kind of a limited repertoire of how it's going to display a problem, right? And so, the pathological study, so the postmortem when somebody died, is kind of one of the few ways we have right now to really be able to understand what has caused the changes that we see. And, we've learned, and we still have so much to learn about this relationship between concussion and chronic traumatic encephalopathy, because, in the brains that we've received, there's young people who have it, there's old people who don't have it and the equal number of concussions. And so this relationship is really, kind of still needs a lot of discovery. I think that's the main thing. We're actively pursuing, understanding in that area, because it's not clear cut. Of course, we do think concussion is the only risk factor for CTE that we know of right now, but what protects some people against CTE and what makes other people so vulnerable to it, we do not understand that.
Absolutely. And I do want to point out the difference. If you are looking to pledge your brain, just make sure that you're pledging it to, and you're becoming a part of an IRB, an internal review board study, and that you're not just signing up for a marketing list, and, a plastic card, that you actually are becoming such a research project. And so that's one of the things that the brain banks that we partner with, you are becoming a participant. What type of participants are you looking for right now? Is there a particular grouping?
our main focus right now are people who were professional athletes who had repeated concussions, and that's mostly professional or high level in a sport or in a contact sport. And that's because that's where, that's where we've discovered it so far, right? So we're trying to kind of maximize our ability to find this relationship, also to understand when the relationship actually doesn't exist for we'd like to bottle what makes a brain resilient to this. So yeah, right now our active study in terms of post-mortem study, we have other studies that are with people who are alive, but the post-mortem is really with people who've had repeated concussions. Yeah, from sports.
Have you had any women with the experience of domestic violence?
So we have had, in terms of brain donation.
Yeah.
Yeah, we have had, I think we've only had one or two, very few.
One of the things that I struggle with in promoting awareness of pledging one's brain and brain donation is also trying to keep down the fear and the panic of, I just saw my doctor and they say I have pre-CTE. And I explain to people that there isn't anything such as pre-CTE. And we've had Willie Stewart on explaining the 12 pillars of health, and your past brain experience is just one. And so do you, it seems to go in waves where people will read an article or they'll hear a particular person, and then you'll get a flood of pre-CTE people. Are you seeing that up there?
Yeah, I mean, we have that. It's a constant problem. At this moment in time, it is not possible to diagnose CTE. We can diagnose, persisting symptoms of concussion. We can diagnose the cognitive issues that that are the consequence of a concussion, and we can diagnose Alzheimer's disease fairly well, but we cannot diagnose CTE.
And so what do you say to patients that they sometimes so fixated that that's the problem? I mean, it's really talking them off the ledge, literally.
Yeah. I mean, I say the same thing. I say we're gonna treat the symptoms, and we're not going to focus on the cause right now, because the underlying cause, we don't actually have a treatment for that, right? So the symptoms that you see in CTE, in other neurodegenerative diseases, in persisting symptoms of concussion, there's a lot overlap, right? Because there's behavioral changes, there's cognitive changes. So we address those. If people have problems with their mood, we can address that. If they have trouble with their sleep, we can address that. If they have post-traumatic stress disorder, we can address that. If they have headaches, we can address. So there's many, many symptoms we can address. And by doing that, we actually can improve quality of life, notwithstanding that we don't know what the underlying cause is.
Absolutely. Charles, do you have any thoughts on that one?
Well, a lot of people come to me worried about CTE. Do I have it? And just as Carmela said, we just don't have good ways of picking out who is going to get it. It's very unfortunate, but that is one of the reasons why we're putting forth so much effort into very carefully examining patients, documenting them, doing what we call longitudinal studies, because we know that CTE doesn't happen, within the first few months of a concussion. It's always years later and sometimes decades later. And we don't understand this lag period. So I try to encourage people and say that, no, it's very, very unlikely that you are going to progress to CTE, because it looks like as we go along, the number of people with repetitive concussions who do end up with CTE is a very small percentage, like maybe 1%. So that's, or maximum 2%. So don't worry about it. That's my usual view. But I would like also to put in a plug for more women offering their brains, because, for example, in certain fields, women concuss more readily than males. Like in basketball and in hockey, there actually is a greater percentage of women players who end up with concussion than men. So there is some susceptibility there. And I might also allude to the fact that it's not just sports that seem to have this additional damaging effect on women, but it's also things like motor vehicle crashes. We've just done a very in-depth study of a couple of hundred people who were concussed in motor vehicle crashes, and the ones who have the most symptoms and the ones who come to us have been like about 80% women, which is really unusual. So why are women occupants of motor vehicle crashes more susceptible to concussion than men? We don't know. And that's a big item for us right now.
Yeah, and I had heard historically the automobile industry did know that women overall fared more poorly and was, a seat design. I know in the military with like the jet fighters, they had to redo the seats for the female pilots because they just didn't anatomically protect a woman the way that the men is. So is it something about how the vehicle or the seatbelt or the forces, or is it something internal within women? And so I'd love to hear from both of you, what has been, 10 years ago to now, what has been the most surprising thing to you that's happened in the brain injury world that you would have never imagined 10 years ago?
Well, as I said, I didn't imagine we'd be this far behind in making discoveries of exactly what it is that, for example, makes women more susceptible in some areas. What is it that leads to CTE in some people and not in others? So that is really quite startling to me and indicates that we really haven't put enough money, we haven't put enough hours, we haven't trained enough people in concussion. We haven't really met the need in research or in clinical management for something as widespread as concussion. In my province alone, and we've done the research ourselves, 150,000 concussions occur in Ontario, in the province of Ontario, with about, what have we got, 8 million people get concussions. So it's like huge numbers, and yet we're not putting forth the effort to solve some of the problems, at least not doing enough, in my view.
And having Rowan's law, this is the death of Rowan Stringer, who is second impact after 2 or 3 hits through concussive, was playing rugby, and her parents met with you, and there was a whole investigation where 45 different recommendations were made, and then eventually became, after several readings, Rowan's law. I mean, you had the most beautiful person who died, and parents, you had everything set to pass this law. And we sort of thought, I was actually there when the third reading, and we thought it would go wildfire throughout all of Canada. So why do you think that where are we right now with Rowan's law? Then I want to get back to Carmela.
Well, Rowan's law has been, in my view, a terrific educational process for the province of Ontario. For the 8 or so million people that live in Ontario, it's been an eye-opener. Like my daughter is an elementary school teacher, and she tells me that she can't go into a school without seeing signs about Rowan's law. So it really has made an impact in our province. And the mystery is why it hasn't had legs and spread to other provinces. Now, as I mentioned before, other provinces have done other things, like they've had elementary school programs, or they've had university level programs to bring the concussion issue to people's attention. But they haven't gone for legislation. And with a lawyer, a colleague of mine, we just wrote an article that'll be published shortly in the Canadian Journal of Neurological Sciences, urging other provinces to get on board and pass Rowan's Law. They have done things. For example, the sports leagues in virtually all the provinces have popularized the importance of telling. So, with the campaign, Children Should Tell. Children and youth who have symptoms of a concussion shouldn't hide it. They want to hide it because they don't want to be taken out of the game and prevented from participating. But concussion is more than sports. And as we said, it's motor vehicle crashes and other things. So the more attention we give to concussion, the more advances we're going to make, and the better off, society will be in order to deal with the concussion problem.
Absolutely. And brain injury has always been the ugly stepchild in the neurology space. I mean, we're the last ones to the table. They pull up a high chair, and the Alzheimer's folks pat us on the head, like in this country, especially. And we don't, in this country, you don't make money. There isn't the pharma, there isn't the scan, concussion clinics, open, close. So I want to give Carmela a chance to talk about where today, what is surprising to you right now that you wouldn't have imagined 10 years ago, where the space is, or, discoveries we've had or haven't made.
Yeah, I think like Charles, I think we're not, as far as I would have liked in 10 years. I'm optimistic that we will get there. But I think that what I am really kind of excited about is that there's been a real paradigm shift in brain diseases, and that I think we realize that we are going to be able to solve them. Which there was a lot of nihilism, this is coming from my area, which is a degenerative area for the most part. And so in that area, there was really not that much hope 10 years ago. And so that's really changed. And so I think this idea that, we need to bring precision medicine, that we need to learn from every patient, which the cancer world has had for a long time, and I think even the cardiac world has, I think is finally arriving to neurology and brain problems. So I think that's what I'm most excited about in our area. But like Charles, I wish we had a test to be able to tell people, yes, you have this, and this is how it's going to play out for you, and this is the best medicine for you. I hope we're going to be there, in the near future, so that we are preventing the consequences of these brain injuries, right? Whether it's persisting symptoms of concussion, which are very debilitating for some people, or the delayed neurodegeneration that can occur afterwards. Both of these, the thing about brain injury is that when it happened, and there's a period of time, so a window of opportunity where you could intervene. And so I'm hoping that we'll get better at that.
Yeah, absolutely. And just personally, I went through a phase, discovering, lining all my concussions up in about 2008, 2009, 2010. And, CTE personally just seemed like that was my future. And I really went down that path psychologically, and I was diagnosed with breast cancer. And they're like, and I'm like, no, you don't understand. I'm a neurology patient. I'm not really interested in the breast cancer thing. So I literally went down this entire track where my fate was all about one thing. And I was like, oh, that, and in the long run, it turns out I had undiagnosed ADHD, and all of these ADHD symptoms that I had connected with my brain injury. So for me, it was going on a stimulant and really focusing on my ADHD. And so I think that so often we, 1 and 1 looks like it equals 2, and it can be an endocrine issue from TBI. I feel like TBI, it's got to be precision medicine because there's so many directions that you can come from. So I wanted to segue to the 2 papers that you just spoke about, and how does long COVID fit into what you're doing as a doctor? Because it's brought in a lot of money, it's brought in interest, it's brought in with people with similar symptoms, it's brought in some sympathy for, oh, that's what it's like to be stuck at home for 6 months. Like, where does COVID fit in for you?
Yeah, I know. I was I volunteered to help out because somebody said, oh, their symptoms sound a lot like what you're talking about all the time, about persisting symptoms of concussion. And, they have brain fog and headaches, and they can't concentrate, and their mood is awry. And I said, sure, I will help out with this. But, oh my Lord, it's, it's difficult because actually there isn't that much money in long COVID. A lot of, like in Canada, there's been a lot of money put towards the acute phase and, helping people not die, which, was a big problem. But in terms of people with persisting symptoms of COVID, there actually hasn't been. And our clinics are really overrun with them, and the patients are waiting a long time, and they don't really know where to get help. So it's turned into a big problem. But again, sex and gender differences, which are important in all diseases, important consideration in all diseases, again, have, risen to a prestigious position, I guess, in COVID, where, in the acute phase, when patients get sick, many more males are worse and die. But in the persisting symptoms of COVID, we're seeing a lot more females afflicted, and even in women who've had more mild COVID. So we don't understand that, needs to be studied. And the 2 papers you're alluding to, where one is we just published with a student from Ottawa, actually, who looked at the vaccine trials and trying to understand how many of them had actually looked at sex and gender differences in terms of side effects, because some side effects were more common in males and some more in females. And now we've just looked at the long COVID data. The paper came out today, looking at this idea and, the evidence in some papers where women seem to have more persisting symptoms, and we're looking at our own data on this. We don't know what it means. We don't know what the cause is, but it just, again, highlights this idea that we need to take sex and gender into consideration when treating people. Obviously, it's only one factor. It's not the only factor, but it is important to consider that.
I think the best sex and gender one, the 5 Ps studies up in Canada, where broke down sex and age. I looked at girls and boys of different ages. So I think for me, sex is immediately, the one that I'm most focused on. But until the hormones, what's going on in the body for an 8-year-old is much different than an 80-year-old, male and female. So, and I think that's where we go back to precision medicine. And, is the correct term, you say you have socialized medicine? I want to make sure I'm politically correct. Socialized medicine versus for-profit medicine down here, and, childhood cancer is tragic, but there's not a lot of money in it, but there's money in, breast cancer and Botox treatment. So we are run here by, I think, profit and who's interested in funding what. And you have socialized medicine where you're trying to bring the most care to the most people in the time that you can do.
Yeah. But it's difficult, right? Because everybody everybody's got a problem, and you know what I mean? Like everybody's story is a sad story, and you want to help everybody, but it's yeah, it's not obvious. I mean, I'm happy we don't have for-profit medicine, I have to say, but it's sometimes a struggle to get everybody the right care at the right time.
Yeah, no, and it was interesting leaving breast cancer, leaving the concussion world and going to the breast cancer world and watching the money flow. And in my 1 year of breast cancer, $325,000 was spent on me. I didn't even have a bizarre, garden variety breast cancer, but I sometimes felt like I could wear a placard, like, paid by, just the amount of money that people made off my 1 year of cancer treatment versus any other thing, and how cooperative everybody is when the money's flowing.
Right. That does help. Yeah.
So do you see COVID as, sort of slowing down or bringing new funding sources and new interest into the brain?
I mean, I hope that there's new money there, because it's going, it's a persisting problem for some people and needs to be addressed. One of the advantages, in quotations, is that a lot of people got COVID at work. So in Ontario, at least, they become part of the workplace compensation. They fall under that. And so their problems need to be addressed and accommodations need to be made. And so, I would hope, but it's a large number of people. Right?
And segue back to Charles, from a historical standpoint, has there ever been anything as big as COVID to come in and our focus needs to change right now? Like where do you see
that's
COVID fitting
really,
into your work?
Yeah, my historical perspective is that this is the biggest thing that's ever happened in medicine in my career, to have so much disruption of daily life by a medical condition. It's really monumental in importance, and has been such a difficult condition to predict. Like, we would never have predicted that we'd now be in our second year of battling this, and we're just now relaxing some of the stringent requirements for isolation and for wearing masks. But it's been monumental, and I think science has been great in providing us with vaccines. I've said several times that I think we'd all be dead without vaccines, that vaccines have been that important, and this virus has been so potent and unpredictable that I really feel we owe our lives to science, and maybe that picture will improve funding for science. Science funding has always been much better in the US than in Canada, which has always been something that's bothered me. Carmela and I depend very much on public philanthropy. Like, when we started our concussion center, we went out on a campaign, not to big business primarily, but to our patients and to our connection, to fund our program. And so we collected about $5 million originally. And then just recently we had another campaign because we were running out of money and government wasn't providing us with research grants. So we decided again to do it on our own. And we did. We just almost successfully completed a second campaign for $5 million. And that's what supports a good part of our staff. Concussion is very multidisciplinary. That's the other really unique thing about concussion, that it takes an army of people, of really dedicated healthcare professionals to meet the problems that patients encounter, like the mental health issues of concussion are so enormous, and they're so expensive to try to treat. Like even social work, getting a social work consultation is a big deal for some people to accomplish. So we went out and collected funds to support a social worker to assist our program. But it's been pretty good. And COVID has made a negative impact on our fundraising, but so it's another reason for hoping that we're at the end of COVID and that we can focus again on other conditions like concussion.
And I'm hoping that the UK government has just put a lot of money and continuing to put a lot of money in brain injury. I'm looking at social workers involved in with brain injury patients. There's a lot of really great things going on in the UK. I'm looking at domestic violence, and I'm looking at the criminal justice system, social justice. So I'm hoping that that's like bubbling up there and will drift across the ocean to us, because I know it's been a long time in coming over there to have funding. So I'm hoping for that for you all. And the piece of social workers, you know, mostly in the United States are travel agents that, you know, take somebody in a hospital bed and they find a rehab bed for them. And that's kind of how we're used, which is frustrating as a social worker. So, you know, I was happy to see that lecture series that included social work. I wanted to give you a chance to talk about that lecture series, and then we'll open it up for some questions.
Well, that's great. Thank you for the opportunity, because it's very dear to our hearts in that we've discovered this very useful way of educating patients in particular. You know, if we don't have enough time to go through all the routines in the office, like which exercises to do and which healthcare professionals to consult, we can do a lot of that on our webinar series. So it's the Canadian Concussion Centre, and we spell it RECENTRE, Canadian Concussion Centre, UHN, which stands for University Health Network.ca. And we have about 15 one-hour segments on our website that people can download and watch at their leisure and learn something about what exercises to do, how to manage headache, what does a social worker do for a concussed patient, for example. So a lot of useful tips, how to deal with computer screen intolerance if people are trying to get back to work and they're having to work in front of a computer for 8 hours a day. How do you do it if you've got headaches and dizziness and all that? So this webinar series is really helpful, mainly for patients, but we've noticed that there's quite a few caregivers who watch it as well. There's quite a few healthcare professionals who watch it. And we now have some people in the US and in a couple of European countries who are also watching it. So please take advantage of it. And I forgot to mention, it's free. And you'll get a chance to see Carmela Tartaglia perform. She's going to be on again in a couple of weeks. So the schedule is on the website as well.
That's awesome. And I do want to put us all now so I can see everybody down there. I wanted to say hi to Mimi, who is leading up our PINK Concussions Canada. So we now have an official Canadian branch, since I haven't been able to fly up there. So did you have any comments or questions you wanted to ask, Mimi? And I'm reading through the chat right now too, to say, people are asking if we could put the website address in the chat.
Okay.
Or not, I can send it out. Oh, yep, there it is. It's up there now.
Okay,
Mamie, did you want to?
Yeah, one question was, how has the pandemic impacted access to care? This is something we've talked about with different guests. In some cases, it seems to have increased access in terms of the online and more remote options. So I was just wondering if you could speak to that a little bit.
Carmela, do you want to handle that, or do you want
Sure.
me to?
Yeah, actually, I think you're right, is that for some people, I think it's actually been very useful because we're doing a lot more remote. We used to always use remote, virtual technology because we see people from way up north, like all over the province. But now I see, until recently, I was seeing maybe 75, 80% of my patients in a virtual manner. So for people who had to travel here and, that was a problem. And let's say, you had a headache by the time you got to our clinics, you were already, feeling quite overwhelmed. I think this has been very helpful to them. Also, if they can't tolerate the screen, we can do telephone visits. So I think in some ways that the pandemic has, helped that. I think for access to resources like physiotherapy and occupational therapy and in some cases psychotherapy, that the pandemic has really wreaked havoc for them.
I see one question in the chat, and maybe you could spin through the chat too. This is a question that we're asked a lot, is what is the window of opportunity to intervene, and I think people always want reassurance, and I think there are places out there where they hear, well, after 1 year, you got what you got. What are your thoughts on, when is that window with a brain injury?
In terms of persisting symptoms of concussion, you mean?
Just when is it too late to reach out and there's no hope of any neuroplasticity or any getting better?
Yeah, so neuroplasticity exists throughout your life until you die. So that's, we know that now, so not going to worry about that one. But what I am going to say is it really depends. I see patients mostly within months or, a few years. And then we try to intervene on the symptoms that we can actually make a difference in, right? We can't fix a brain right now. We can fix symptoms that actually impact the brain. And sometimes when people understand that, if you have a daily headache, your concentration is just not going to be great, right? Because basically your brain is multitasking all the time. If you have anxiety, it's going to be multitasking all the time. You can't register information. If you don't sleep well because you had a concussion and it's changed your sleep, or you've developed sleep apnea, going to impact the brain. So when we fix those symptoms, people actually feel better. And we, didn't change the brain per se, but fixing those problems changed the brain, right? So in that way, I think the window of opportunity could be quite long, but it depends on, what has been tried, how many things there are to try. Because I do see people sometimes who've been on Tylenol for 2 years and complain that they have a headache. Well, that would not be surprising because everybody would have a headache after 2 years of Tylenol.
Yeah, and Charles, what are your thoughts on, how late is too late to come in for some help?
Well, I agree with what Carmela has said. Essentially, the earlier the better, because I do feel that certain patterns become ingrained, and it's better to try to treat that as early as possible. So I do believe in early treatment, but I don't think it's ever too late to try new approaches, because there are new approaches. For example, in treating the mental health problems of concussion, when we started this, there were probably about a half a dozen drugs that were helpful. Now there's about 20. So that's a huge increase in our armamentarium to help people. We can do a lot more now than we previously could. So someone who was refractory to treatment or didn't benefit from treatment, 5 years ago, I think can still be helped. We can still make a difference.
Absolutely. And I see a difference just with our support groups. We're over 8,000 in our support groups right now, and just connecting with other people, learning from, their highs and lows in their journey. And, I think we all now understand the effects of isolation, the effects of not having a social system, the effects of being alone with Netflix every night and, whatever pint of ice cream that, is your comfort zone. And I think, in a way, there's a lot more sympathy for, how isolation itself can just cause affect the quality of our lives, and if you can, there's virtual support groups. We have them. Love Your Brain has some great ones, and just finding ways to connect with other people, even if that's the time frame when you're waiting for a doctor's appointment, finding, that connection. Nat, you had a question. I saw your hand up.
Thank you. I think it was pretty much discussed. The window of opportunity closing on improvement is it never closes. I think it's the challenge is the expectation of what that's going to look like. And we want that instant stir and serve, instant oatmeal, instant everything. And that is probably the largest and most difficult part of it to take in. And for a lot of the cases I'm working with, it's when the apathy sets in and gets in the way of the trajectory to recover or create new skill sets. I'm just finding a lot of, oh yeah, they said I could have this great tool, but I have to get the request for that accommodation to be rewritten, and that's just too much work. So then they're cut off from this wonderful tool that needed to be written up in a very specific way. And the specificity skills are not always in the hands of your provider. But that just, I give up, is the constant hitting, you hit the wall in, say, in SLP, speech language pathology, you hit the wall, and what you want to do is get through that wall, and you're going to hit another wall and they get through that wall. And how do we best support people in not going into the apathy setting as they're trying to move through, I've got to hit that wall and then I'm going to get through it, and then yay, celebrate.
Yeah, no, absolutely. I was just with my dad in Florida, who can't hear anything, is very isolated, and, his hearing aids don't work. And I found out he got them 5 years ago. He's never had them retested. I don't even know they plug in, a light comes on, and, it's just one of those things. He's like, well, they don't work. Well, you haven't been back to the doctor in 5 years. He's like, well, they gave them to me. I didn't realize it was something you had to adjust. So just things like that, so it's again, it's the time and the energy in this country, the expense in Canada, the wait to continually, advocate for ourselves. And I think, unfortunately, a lot of the time the women don't have wives that are doing that for us, and I think, in general, if you look at sort of more of a traditional household, the men may have a mother, a wife, a sister who may assist with that more. And then, of course, there are wonderful husbands also doing it too. But I do find that women seem to be more alone, with less money, with less insurance, with less security, to try to battle these pieces. So we're at 3:00. Mamie, is there any burning question that we forgot? And then I want to give both of you a chance for a final comment of any type you'd like.
One question from the chat would be about the role of nervous system regulation. What is the relationship between the nervous system and overcoming concussion and post-concussion?
Not sure what you mean by nervous system regulation.
Yeah.
Like general stress, anxiety, like that type of thing.
A huge effect. If you have untreated anxiety, depression, PTSD, it's very difficult to overcome other symptoms like headaches and dizziness. So that's a good example of the necessity to treat the whole patient. Like we can't just treat one of the symptoms. And as I mentioned before, concussion is such a disciplinary field that people need often people need an army of healthcare professionals that have an interest to try to help them. Yeah. And that's one of the big problems of concussion, that all of those consultants, all of those individuals, even, in our own hospital, we have difficulty in keeping the team available and able to respond to patients. Yeah.
So final comments. Carmela, do you have a final wrap up thing you'd like to say? We've loved having you both on. This has been really great.
No, thank you all for coming and being here. Yeah, no, and thanks for the invite. It's great to, I think both Charles and I love to talk about the brain, and we're both passionate about this and hoping that we figure out, some of the mysteries, and happy to see other people are interested in learning about that.
Absolutely. And Charles?
Well, Katherine, I think you are a fantastic cheerleader for concussion. We need people like you to provide the, platform for improvement, for helping people. I think you're an amazing platform for all of this education, prevention, treatment, advocating for all of those things is really incredible. I don't know how you do it. And maybe you revealed one of your talents or the reason for it, that you have ADHD, or you had ADHD, because to keep, just to keep all of this going requires a huge amount of energy. So keep it up. Your ADHD is a blessing.
It is definitely a superpower I've had to learn to control. And I do want to thank you, because honestly, and the reason that I knew to invite the Stringers to the United States to 2016 to give them an American award is because I knew how cool it was when I got asked to Canada to give a talk. Well, I'm an international speaker now. So I knew from you asking me up there that bringing them down here would give them some credibility. So, I want to thank you for all that you've done, both of you, to promote, what we were doing down here. And, that's what's really fun working with the UK and working with Australia, because it, once you can say, well, over, in this country, they're doing something. So hopefully from an international basis, we can keep moving forward, and we can come back in another 10 years and talk about the exciting things that you all have discovered. So I'm really, it makes me sleep well at night knowing you all are working on this. So thank you, everybody.